You want to view it? So there's my name, and there's some of my stuff there. Basically, I was an intensive care doctor most of my career until about 10 years ago, and then I transitioned to being a hospice doctor in 2012, and then I switched to working in a health plan in 2017, the end of there, and that's what I'm still doing. I have been very active in health advocacy. That's where I met Judd. I got involved in the medical society, and then I'll show you my next slide, if I can. And then I got very involved with Doctors for America, which was a group that formed after the 2008 election. And we were very active in helping pass the Affordable Care Act. Our founder, Vivek Murthy, went on to become Surgeon General under Obama. We all got to go to the White House. I had my 15 minutes of fame on the LA Times and a bunch of other newspapers around the world. That's me, if you can't tell. I've still stayed involved in healthcare advocacy. And I actually earned a graduate certificate at Thomas Jefferson in health policy, and I've been teaching. I was teaching for them for about 5 years. I haven't done it in the last couple of years just because I got so busy. But it's what I'm really interested in. I'm passionate about social justice in healthcare, and that's what I've been fighting for. And the reason I came to this talk and this title is because I found some time to try to get more active again, and found these 3 books that we're going to talk about. So this is going to be like a book club where I'm the only one that's read the book. So be it. I think you'll get a fair amount out of this, even not having read the books. Oops, sorry. Still learning, sorry. So that's my background. And I put this talk together actually for our Doctors for America meeting, which we had in November. And and the way they work it is you put it up on the little message board and say, here's my topic, and then people sign up for it. And I thought I'd maybe get 3 or 4 people in my talk. And about an hour before I was going to start, they said we had to move you to the bigger room because there's a lot of interest in figuring out how to talk about healthcare reform in a way that means something to people that aren't doctors and that aren't already committed to social justice and healthcare reform. So it was a great session, and so you're essentially going to get the same set of slides they did, but I have added a couple things since then. I have been a big fan of Uwe Reinhardt, and if you don't know who Uwe Reinhardt is, he's a Princeton economist. Actually, he's the late Princeton economist. He died in 2017, I believe. But he was a brilliant healthcare economist, and he wrote tons of articles, and he was a great lecturer, and he was actually really funny. And anyway, he would tear these things down into the important parts. And this was one of the things he said. He said, a common incantation during debates on health reform is that we all want the same thing. We just disagree on how best to get there. And in more colorful language, he would say that is bullshit, but that is rubbish. And he's exactly right. And what he told us would happen, and this is exactly what happens, is we get into a debate about whether we should have Medicare for all or some other form of universal health care. And we then go down these rabbit holes of, well, how should we pay for it? Or how should we implement it? Or should we do a public option? Or should we do that kind of thing? And we go down these rabbit holes, and we never have the discussion about whether we should have universal health care. And whenever we do that, whenever we get down those rabbit holes, the status quo wins. We don't change anything because we've never had the debate that Canadians have had, that Germany has had, that England has had, that this is something we want to do. So we go down these rabbit holes. In fact, I was at the Medical Society annual meeting in the fall, and there was a single payer resolution, and Judd knows how this works. We have these reference committees, and in the reference committees, you get up and you make your case, and you make the argument for why you want to do this, that, or the other. And immediately, an anesthesiologist stood up and started talking about how his reimbursement for his 15-minute time units when he was supervising a nurse practitioner weren't adequate as it is, and what would happen if we had single payer. And then a radiologist stood up and said, well, my reimbursement for reading chest x-rays isn't adequate now. What will happen if we have single payer? So it devolved into a silly discussion about the reimbursement for these two guys. And of course it went nowhere, which is how it always ends up working. But I think one of the things that really upset me.
Let me ask you this hypothetical question. A healthy 30-year-old young man has a good job, makes a good living, but decides, you know what, I'm not going to spend $200 or $300 a month for health insurance because I'm healthy, I don't need it. But something terrible happens, all of a sudden he needs it. Who's going to pay for if he goes into a coma, for example? Who pays for that?
In a society that you accept welfareism and socialism, he expects the government to take care of it.
What do you want?
But what he should do is whatever he wants to do and assume responsibility for himself. And my advice to him would have a major medical policy, but not before.
But he doesn't have that. He doesn't have it, and he needs intensive care for 6 months. Who pays?
That's what freedom is all about, taking your own risks. This whole idea that you have to prepare and take care of everybody.
Are you saying the society should just let him die?
No. I practiced medicine before we had Medicaid in the early 1960s when I got out of medical school. I practiced at Santa Rosa Hospital in San Antonio, and the churches took care of them. We never turned anybody away from the hospital, and we've given up on this whole concept that we might take care of ourselves and assume.
That was very upsetting to me at the time that it happened, and it still upsets me to watch that again. As a normal human being, I think that's upsetting to us all. As a physician or a nurse or somebody who's is committed to helping people, this is just anathema to us, and I don't know. It just makes no sense to me. But that's where we are. Go ahead. So what's the thinking behind it? The thinking behind that is summarized here, and there really is a meanness of spirit in America. We have this puritanical streak about who's deserving and who's undeserving, and this is an article that talks about it, and this is from a conservative writer, and he writes, people don't want to help what they consider losers. They don't want people to take advantage of the rest of us. I went to Keystone Progress Summit last year for a few hours. I was actually after the 2018 election, and there were several Democratic candidates who'd lost state races, and all four of them, without prompting really, said when they talked to conservative voters, the thing they were most afraid of is that having other people get over on them. This is like just such an underlying paranoia in conservative mindset that, I've heard that, and I've heard this, and it got me thinking, well, how do you overcome that? What do you do to beat that? And I'm sure you've all seen this too. The injustice in healthcare is shocking and inhumane. And we've been talking about this forever, right? I mean, this goes back to Harry Truman. It goes back to the passage of Medicare with the American Medical Association trotting out Ronald Reagan to say this is socialism. We don't really want to do this. And then with the Clinton health plan in the 90s. And this is sort of where I first heard of Uwe Reinhardt, who wrote this. And basically what he asks here, and this was in the Journal of the American Medical Association, what he asks is, should the child of a rich man get better health care or have access to health care when the child of a poor person should not? And he goes on, he's on over the years has argued, to what extent are we our brother's keepers in healthcare? And he was actually a German immigrant, and he had an accent, but I can tell you, reading and communicating with him, it really stung him that Americans, of all the nations on the planet, Americans have stubbornly said, no, we're not going to take care of the least among us. We're not going to do that. And, part of that is, almost 100 years of conservative fear mongering about what socialized medicine means, what universal health care means, who's deserving and who's undeserving. And so what brought me to this point is, how do we overcome this? how do we do this? This letter in the New York Times a few years back, this was in 2009, really cuts to the quick to me too. It was an article about the Dutch healthcare system, and this professor who did the semesters at sea said, the last time I taught a semester C program, I found it necessary to interpret for our students the rich social capital that runs through Northern European societies. What they knew and had read in their guidebooks was that not many people went to church in these countries, especially compared to the florid religiosity of the United States. So their working assumption was that Americans take religion seriously and Europeans don't. The thought that amazed them, the new thought that amazed them, was that the unchurched Europeans live in social democracies deeply saturated with historic Christian values, while the much churched Americans celebrate a society characterized by ruthless social Darwinism that the God of the Bible, Old and New Testament alike, denounces. Is basically saying, you know, we talk a good game in America, but we don't abide by it. This is all actually just prelude to the main points I want to get to. But Wendell Potter, if you don't know him, he was a healthcare executive at Cigna, and then in 2008 or so, he came around and had an epiphany and came to the other side. And what he pointed out is he was one of the people that killed the Clinton healthcare reform, and his company was planning to kill the Affordable Care Act too. The whole industry was, and he had an epiphany, which I can tell you about if you want. But you know, basically what he says is, here's their playbook, and this is it. He calls it FUD: fear, uncertainty, and doubt. And if you plant enough fear, uncertainty, and doubt in the public's minds, everybody goes back to the status quo as their second option. And what we're going to talk about tonight is why is that and how does that work? And this guy, this is Frank Luntz's playbook from 2009, The Language of Healthcare, 2009, he called it. It's a 28-page document. And basically, he did a masterful job of researching how conservatives should talk about healthcare, how to make the language impact the most people. And it's masterful. It's 28 pages, and he does a magnificent job of telling his people to call it a bureaucracy, talk about waiting times, all these things that they've worked on for 40, 50 years and planting in our brains. He wants the conservatives talking to the media to emphasize these and activate those areas in the brain that make them fearful and say, oh, well, we can't do that. You probably are all old enough to remember the old Harry and Louise commercials during the Clinton healthcare reform. Basically, they were just playing on fear, uncertainty, and doubt. Oh, what's going to happen if the government does this? And it worked masterfully. So here's the main thrust of this talk tonight. We're going to be talking about 3 books, and I read them all about the same time, and it struck me that they really are a good trilogy of explaining why we're here and why we can't get anywhere and why we keep getting beat in the court of public opinion. This is the first one. This is a Michael Lewis book. He's the guy that wrote Moneyball, The Big Short. He's a great historical or nonfiction writer. And this is the story of 2 researchers out of Israel, Amos Tversky and Daniel Kahneman, who developed a friendship and a collaboration in Israel as they were growing up and working in the army. And the book is wonderful because it's their story, and it's really a love story about them. But their collaboration was the thing that gave us the stuff we know now as cognitive science, as behavioral economics. They call it prospect theory. And the part of the book that I focus on is the prospect theory and how we think. And so that's what I'm going to talk about here. The entire book is wonderful. It really is a great story. So I won't spoil it for you, but it's a really good book. So what they learned in basically studying students and studying people in real life, is that thinking is divided into 2 subsets. System 1 thinking is fast and intuitive. It's confident, overly confident according to them. And System 2 thinking is the thinking we think about when we think of our rational mind, when we think of our Enlightenment principles and how we arrive at decisions and how we arrived at our Declaration of Independence and our Constitution. It's how we think rationally. But unfortunately, system one thinking is the thinking we do most often. And it's very rapid. It takes over our brains. It is confident. When you think with your gut, you are very confident about it. And we've seen that in a few presidents, haven't we? So it's a feeling. It makes you think you're right. And it is very confident. So it's a problem, because if you're not thinking right, you're going to make mistakes. So I'm going to go through a few slides just showing some of the principles, and there's a lot more, but you'll get the idea. So international travelers are asked, how much would you pay for an insurance policy that pays $100,000 in case of death for any reason? And then how much would you pay for insurance that pays $100,000 in case of death in a terror incident? I don't know how we're going to do audience interaction, but if you stop and think with systems two thinking and think rationally, well, why would you pay any more for a policy that pays you only in case of a death in terror versus $100,000 for any cause? Well, you wouldn't if you're thinking rationally. But when they do this test, the fear of thinking about terror. So when you ask the question, you put terror incident, you put them in that mindset of thinking of terror, thinking of fear. And when you ask them how much they'd pay, they would pay on average twice as much for the second policy, because their fear has been activated. And so they're going to pay more. Here's the other one. And this is, you'll see what this is about. So in addition to whatever you have on, you have been given $1,000. And you are now asked to choose one of these options, and you have to choose one. A 50% chance to win $1,000 or get $500 for sure. The second part of this, in addition to what you ever own or what you own, you have been given $2,000. You are now asked to choose one of these options. 50% chance to lose $1,000 or lose $500 for sure. So I'll give you a second to think about those two situations. One is gambling on gaining, and the other is gambling on losing, or a for sure win or a for sure loss. And the outcomes mathematically are identical. 50% chance you'll end up with $2,000, 50% $1,000, or $1,500 with certainty. What people fear is loss. And so they almost uniformly, when you offer them the gain, they will take the sure gain. If you give them the choice about the loss, that you will for sure lose 500 or maybe lose 1,000, they will 2-to-1 choose to gamble to avoid the loss. We are very risk averse is the bottom line to that. We all know that intuitively. These guys have studied it, and it's been confirmed, and you know it intuitively as you think about it. That's the way people behave. What made me want to apply that here was, you probably heard that, and this is a Kaiser Family Foundation study. I don't remember when, exact January of this year. And it's a tracking poll, and they ask this question a lot. So do you oppose having a national health plan, sometimes Medicare for all? And 56% favored it at the time this studies were done. And did you favor guaranteeing health care as a right for all Americans, and so on? If you add the question, what if we eliminate your private health insurance, your employer health insurance, the support drops almost, not quite in half, but substantially, from 56% to 37%. Because what you've done is you've framed the question Medicare for all. In your head, you're thinking, well, that's a bonus, that's great, we'll keep going that way, and we'll favor gaining. But as soon as you offer the possibility that they're going to lose something, private health insurance, which depending on how you feel about it, you probably are not a big fan anyway, but even the prospect of losing something that you don't really like gives you that huge loss in support. And again, that's where we're always behind the 8 ball. As soon as the conservative speakers can activate that fear in our brain, we're fighting from behind. And one of the key insights that these guys made, Daniel Kahneman made, is we don't choose between things, we choose between descriptions of things. So how you frame that question about, so we will eliminate all private health insurance. Well, I'm sure you can think in your head, there's a lot better ways to frame that, right? There's ways of framing it that it's a gain. We're going to rein in the private health insurers and make them comply with a strict set of rules, and they have to cover X, Y, that kind of thing. I'm sure you can do it on your own. It really is all about the framing. It's all about how we describe something to someone and how we get their brain to react to it. I'll give you another example. So Linda's 31 years old, single, outspoken, and very bright. She majored in philosophy. As a student, she was deeply concerned with issues of discrimination and social justice, and also participated in anti-nuclear demonstrations. Which statement is more likely correct? Linda is a bank teller who is active in the feminist movement, or Linda is a bank teller. When they tested this with students and professors and the like, Linda is a bank teller who is active in the feminist movement was, I think, 2 to 1 more likely to be picked. But obviously, that's systems one thinking. When you think logically, rationally, and you make a Venn diagram, well, which is more likely? In the whole subset of, or set of bank tellers, the subset of feminist bank tellers is a smaller group. And yet, we confidently picked that first one with our systems one thinking. I think this is my last one, so we'll move on. But I think they're very instructive. I think they really help. So you can read that one. A bat and a ball together cost $1.10. The bat costs $1 more than the ball. How much does the ball cost? The immediate answer that almost certainly popped into your head was 10 cents, and the bat was $1, right? Of course, that's not right. We intuit the correct answer. We hear $1.10, we hear $1 difference, we say 10, and if you spend more than 10 seconds on it, you'll get the right answer. But we do it confidently with systems one thinking. If we're trained to think that way, that's the way we think. Okay, I'm sorry, doing one more because this speaks to another important concept. So which is more common, words that begin with R or words that have R as their third letter? Or both A and B are about the same, within 5% of each other. So as you're starting to think about this, you're thinking about words that have R at the beginning, and then you're thinking about words that have R as the third letter. Your brain is much more easily able to come up with words that begin with R than words that have R as their third letter. So most people answer more words begin with R, but as the numbers show you there, no, it's about twice as many begin or have R in the third letter. But that's what we think of. So there's two things here. This is called availability theory, the things that come to your mind, and recency theory. If you recently thought of words that begin with R, and you don't usually think about words as having R in their third letter, so the words, so recency and availability are the things that come into your mind. And this is what, again, is so useful for conservatives in debating healthcare, because what actually happens in the world versus what's actually covered in the news. I mean, when you think about Canadian healthcare or British healthcare, conservatives have done a masterful job of making us think of, two things: dying waiting for care and waiting times for all procedures. What actually happens in the world is far different than that, but they have those things planted in our heads in recency, that we've heard of them not that long ago, and we hear them frequently. As someone who studies international healthcare, I can tell you I'm just the opposite. I can give you, a dozen stories about great things that happen in Canada that don't happen here in Britain and Germany and so on. So I have the exact opposite availability in my brain. But most lay people do not. They're still getting bombarded in the media with the horror stories of people dying in Canada and Britain waiting for procedures. And this goes way back. This is Ronald Reagan. It's an interesting story, but the AMA paid him to do an LP speaking out against socialized medicine, and it's pretty funny in retrospect because Medicare did get passed, but it's one of those things that is just in our psyches. And what I think we need to do, and this is just a slide of some of the horror stories of things that happen in America on a routine basis. And I have, dozens and dozens and dozens of these slides about the horrible things that happen in America. But we don't get that message out. We get the occasional news story like this and that, but we don't have a media machine like Fox News, and we don't have think tanks and so on putting out this message and pointing out the problems. We're getting a little bit better, but we're way, way, way behind the 8 ball. So my final thought on this about systems one thinking is this from Nick Hornby. I've been thinking with my gut since I was 14 years old, and frankly speaking, between you and me, I have come to the conclusion that my guts have shit for brains. And I think that is dead on. A good way to end that section. So this is the next book. This is Priced Out. This is Uwe Reinhardt's last book. And I'm not going to say a whole lot about it. I urge you to read it because it's got 2 things in it. It's got, the first part is just, and he calls it America's Healthcare Wonderland. It doesn't mean wonder in the sense of awe and wonderful, but wonderland in the sense of just craziness. And he spends a lot of time in the book going through how we spend our dollars in the U.S. System, what drives that spending, how we're being priced out of our own healthcare. And it's very fascinating. And if you don't have a background in healthcare policy, it's really informative. And he's got some great examples and things that I think as I go forward and trying to advance this approach to thinking about healthcare that are going to be very useful to paint the picture to Americans that aren't convinced that we live in a crazy system and we have to do better. He talks about the complexity, the confusion, the cost, the waste, the avarice, the immorality, the injustice. It's just rampant in American healthcare. And it is going to be very difficult to overcome. When I tell people, about this, I say, we have $1 trillion industry that's going to fight like hell to prevent us from doing anything to take away their livelihoods. We have the highest prices for everything in healthcare in the world, by far. It's not even close. And I have tons of slides about that too, but we pay 10 times for medications that European countries do, for example, and especially the high-end medicines, we pay way more. I was just doing a case today for a medication for children with genetic disease, spinal muscular atrophy. It's $750,000 for a course of treatment for the first year. And then it's $250,000 a year after that. We behave as if the sky is the limit and we have no upper limit, except that we do have an upper limit because we don't want to pay for healthcare for people that don't deserve it. Then the second half of his book is the ethical perspective, and it's some of the things that I already showed you that he talks about. What's our role? How are we our brother's keepers? And I won't go into it in too much depth here, but I highly recommend the book. It's really well done. The basic argument, though, the ethical argument that he makes, and this is the same slide you saw before, what extent should we be our poor brothers and sisters keepers for healthcare? But it comes down to, is healthcare a commodity or is it a social good? And Americans, well, let me say this. So what happens when we have these discussions is liberals want to talk about it as a social good, conservatives want to talk about it as a market good. And there's another author named Dan Ariely out of Harvard who does a lot of research, like we're talking about with cognitive science. And what he points out is that when we make it a social argument, we win. When we make it a economic argument, we lose. And conservatives have been spectacular in making this they're making this play on their turf. And so every time we start talking about it on their turf, and I see my colleagues in medicine do this all the time, we start getting in the weeds and going down those rabbit holes that I was just talking about and making this about economics, we lose because it's an economic argument. And that is not where our moral high ground is. Our moral high ground is, how do we make this a social good? How do we make this good for all of us? How do we make this about being our poorer brothers and sisters keepers? How do we make this about whatsoever you do for the least of these? And whatever religious tradition you're in, you have some form of that. So we lose ground every time we make it about economics. So this is a little bit more along those lines. Americans have a fiery and fierce independence that supports the myth that literally anyone through hard work and determination can rise out of poverty and become rich and prosperous. Anyone who isn't working hard enough or doesn't have enough determination, in effect, they're a loser, and nobody wants to pay for the health care of the losers. This was a few years ago, but I don't know if any of you read Nick Kristof in the New York Times, but he just had an article about this maybe 2 weeks ago, and he has a book out, Tightrope, that I haven't read yet, but it sounds like it's very good. But one of the points he makes is that, the conservative meme is pull yourself up by your bootstraps, and he points out in the article that actually means the opposite of what we now take it to mean. It came in the late 19th century. And what it meant was obviously something so stupid that you couldn't possibly do it. You couldn't possibly pull yourself up by your bootstraps. And that's what it meant. It was an impossible task. But now here we are a century and a half later, and we're talking about it as if it's something that Americans should routinely do, is pull themselves up by their bootstraps and become rich and famous, or at least get a job good enough to have private health insurance, which I think we all know is nonsense. So we have a lot of ground to cover. We have a lot of groundwork to do before we can convince a big enough chunk of Americans that this is the right thing to do. And that's sort of the point of this talk. I had an email exchange with Uwe a few years ago before he died. And he said, the problem isn't in the US isn't that the public, plebes, is confused. He said they just generally eat what the unified ruling elite serve. And what they serve is what corporate America wants, what the military or the medical industrial complex wants. So they essentially believe when pharma says, if you restrain us, you won't have any cures and you'll die in a gulag. They believe the health insurance companies when they say, well, you need us or otherwise you wouldn't be able to get care. All the nonsense is fed to the public by our ruling elite, and it's absorbed. So the problem isn't that they don't share a consensus. No, the problem is that the elite does not share a consensus on what the social ethic governing American healthcare should be. I'm not sure it will ever reach such a consensus. So in my view, any meeting of the sort I had in mind, I was proposing that we have a large meeting trying to get people to come around to this idea that this is a social good. And he I think was relatively rightly dismissive of the idea that we could accomplish anything on that basis. I think he was right then, and that's sort of why I'm doing this work now, is because I think we have to figure out a way around that. And I think these books and cognitive science might give us a way to finally win this battle. This I've already talked to you about. The term Uwe uses, by the way, for that thing about people getting over on you is called social envy. The idea that someone who didn't work as hard as you is going to get something either provided by you or that you deserve and you aren't getting. And that's social envy. And that's the meanness of spirit and so on. And there's lots of more arguments to make about this. There's just a few. I really like the LBJ one. I read a book about the passage of Medicare, and LBJ kept emphasizing dignity, because at the time the Medicare debate was about seniors basically being spent into poverty. As we see now, when you become a dual eligible on Medicare and Medicaid, you're spent into poverty and you lose your dignity of being able to support yourself, and your kids have to help you and so on. And he made that a cornerstone of getting Medicare past dignity. And I think that's very powerful. We can talk about all this stuff at the end, but we as progressives have to do a better job of framing these arguments so that we can win, and so they don't keep going down the rabbit hole of market economics. And just so you know that one of the reasons I have hope is that in 2004, I think this was, the Charter on Medical Professionalism was written by the American Board of Internal Medicine. Long story short, I'll just go through this really quickly. It basically says that physicians as professionals must promote social justice in the healthcare system, including the fair distribution of healthcare resources. Now, internists are generally progressive as a group, and so, fine, they passed this, and that you'd think that would be the end of it. But what shocked me was every specialty that you can think of, orthopedic surgeons, ENT, radiology, everybody adopted this, and I was sort of shocked. And then I thought about it for a while, and I thought of the reason, because I was on the board of trustees in the medical society for years. And what I found was that the people who were on the board, the people who were leaders in the profession, could be shamed. And Judd will back me up on this. I used to shame them all the time about their duty as medical professionals. And I think what happens in organizations like this is the people that rise to the top of leadership would read that and say, yeah, we cannot say no to this. We cannot say no that there should be a fair distribution of healthcare resources. So this gives me hope that we can enlist enough physicians and nurses and other healthcare professionals to try to push this forward. And I think if we do a good job of framing it and making it about, taking care of the least of these, and there's a whole bunch of other framing techniques, but I think we can do this, but we have to spend a few years making our argument and taking the argument out of their field. Whenever the argument is in their territory, we lose. So this is the final book, and I urge you to get a copy of this because it's almost like a chapter by chapter playbook of all the villains in healthcare. And I teach health policy. I think I know a lot about health policy, but as I read this book, chapter and verse, she goes through all the insanity of basically people profiteering off of healthcare, off of your healthcare, off of my healthcare. And every page would make me angry. It would make me so angry about the system we're living in and we're putting up with. So I urge you to get it, and I'm going to talk a little bit about it here. She has some tongue-in-cheek rules for American healthcare that are spot on. There's, I think, 9 of them. Always opt for more treatment. Choose the most expensive option that's available. And you think, well, that's silly. And then she goes through and pretty much every chapter, she'll cite an example and she'll refer back to these rules and show you, yeah, this is what they're doing. They're not choosing the most cost-effective treatment. They're not choosing to have a discussion about whether to continue treatment. Always opt for more treatment. Choose the most expensive option that's available. And you go through these and you'll see it's better to treat a disease over a lifetime than to cure it, right? Diabetes, high blood pressure, all these things. Providing good care is less important than good amenities and marketing. You're much better if your hospital looks like a fancy hotel than if it is the best of the best of the best in safety and quality. Some of the things that are most infuriating, as technology ages, you would think the treatment would get cheaper, but no, it gets more expensive in America. Same with drug prices. As they get older and go generic, the rule used to be that you become generic and you go on the $4 Walmart drug list. But no, not now. Now somebody buys the patent and gets exclusive rights to it. What's the guy's name? Martin Scarelli or whatever that did that a few years ago and became a villain. But that's routine. That was an egregious example, but it occurs on a daily basis in American healthcare, and we put up with it. More competitors doesn't mean lower prices. As we often see, competitors don't actually collude, but they don't stop each other, and they all just agree to let the prices go up. It's not a spoken out loud agreement, but it's an agreement. Large providers, we have UPMC here in Pittsburgh, and they're creeping into your area vigorously too. That doesn't result in lower costs. They always told us that if we had an integrated delivery system, that was the euphemism, where the insurance plan owned the hospitals and the doctors and so on, that would lower costs with efficiency. And exactly the opposite happens. Then they're unlimited in what they can charge and what they can do, and the prices just expand and expand and expand. There are no fixed prices for anything. The price of anything in healthcare is what the market will bear. The drug I told you that cost $750,000 for the initial course of treatment does not cost $750,000 to produce. It doesn't cost $350,000 to produce. It doesn't cost $100,000 to produce, but it's what the market will bear. And so they're going to charge that. Okay, I'll stop with these here and go. And here's the chapters. And this, it's like a rogues gallery. The insurance industry, hospitals, physicians. We're not blameless as a physician. Pharmaceuticals, medical devices, testing, ancillary services, contractors, you'd be amazed how many millions of emails I get from billing services and coding services and collections, and it's disgusting is what it really is. Research and good works for profit, and she gives examples of like the Diabetes Foundation basically selling its soul to get some drug company money. It's very sad. Some of the things that the organizations we think are just pure pro bono are co-opted by the money. Conglomerates I just talked about. Healthcare is a pure business, and as long as we keep accepting that it's a pure business, we're not going to win this battle. And she talks a bit about the Affordable Care Act. So that's her diagnosis. She calls this part of the book the H&P, the history and physical. Here's what's wrong with the system. And then she spends the second part of the book, it's a smaller part, but how to overcome this. And this part of the book was really disappointing to me because basically it was, okay, you get a doctor's bill. Here's what you do to fight back. And here's how you get to, find out what you really owe and the hospital bills and insurance thing. And it's just so disheartening to think that we are still at this point where we just accept that. Europeans don't accept this as part of life. They don't accept spending 10 hours every year figuring out which insurance plan works best for them. They don't accept doing prior authorization for weeks waiting to get your procedure approved. They just don't do that. That's not acceptable. And we just take it as a cost of doing business. And if it were saving us money, yeah, maybe that would be worthwhile, but it doesn't. It drives the prices up. So it's just maddening. And I think that's fine. Where did I find that? And this came out in the New York Times. When was that? September. And it's exactly right. Actually, Teresa's a friend of mine. We've talked about this before. The entire system is a giant workaround. Everything we do, she's talking about nurses stockpiling medicine, because I told her, in my ICU, the nurses had a stash of the medicines you needed the medicines you needed right away. They had a stash of them because they knew that if they asked for them in the normal way they're supposed to ask for them, it would take an hour or two to get them. So they had them. And from that to everything I just talked about, the prior authorization and so on, it's all a big jury-rigged mess. And she's absolutely right. I think I'm going to stop there. And
Chris, this is Judd. One of the when we talked earlier, you had talked about starting a nonprofit.
mm-hmm.
Do you want to talk a little bit about what you're thinking of, or are we too early on in the process?
Oh, it's way early, but I'll just tell you, it's based on this and what I've found. I've been looking to see, well, is anybody doing research in this from the liberal side? From the conservative side, you have Frank Luntz, and you have these think tanks that are pouring, the Koch brothers network is pouring tons of money into this. I tried looking in Google Scholar and PubMed, and is anybody doing research on cognitive science and healthcare reform? And the answer, as best I can tell, is no. So I've reached out to some PhDs at Carnegie Mellon and Pitt, and the answer is no. Nobody has even touched this as far as I can tell. And, I have, lots of people banging on my door for Medicare for all and, supporting Medicare for all. And my response is nothing's going to happen. We have not laid the groundwork to allow anything to happen, because what's going to happen is we're going to propose something and they're going to fear, uncertainty, and doubt. socialism, you're going to die in a gulag, and we're going to lose. Until we have the infrastructure, and I think it has to be doctors and nurses primarily, until we have the infrastructure of people who know how to pivot from those arguments, to pivot to the social justice, to the moral component, to the correct cognitive framing. Until we have an army of people that can do that, we'll keep losing. So the idea for my nonprofit is, one, to do a little bit of research, and two, to start doing events where I can and train the trainer, and we can all learn how to do this. Because I think we're doomed until we take back the high ground, and we have lost the high ground to mammon, to the marketplace, and until we turn it around to make this about society and a social question, we're going to continue to lose. So that's where I'm headed with this. But I'm going to start the paperwork on a not-for-profit, and maybe in a year I'll have one actually set up, and we'll see how it goes.
That's great. When we were talking before it, the example I used, because you got to put a face on this. You have to. People respond to narrative,
Yeah.
And they respond to actual people, and it's been used effectively by a lot of organizations. And the one I cited to you was, the trial lawyers would, we'd have these big tort reform rallies and, day at the Capitol, and the trial lawyers would show up. There'd be about, number one, they had a lot of funding because they gave generously, but they'd also show up with a few people in wheelchairs who had quote unquote been injured by doctors. And the doctors would show up in masks and white coats and all that. And the press would paint it as the BMW rally or whatever. And they'd interview these patients who had these injured persons. And that's what, that was the image you got. And the trial lawyers knew. They knew what they were, they knew that a couple well-placed stories about real live people trumped anything that, this big fancy rally with lots of doctors in nice white coats and,
well, we're trying to do both. So one of the things that Doctors for America, the thing I've been with them for more than 10 years now, has always been about is narrative. And one of the traditions at our meetings was, when you stand up, you tell people why you were there. And the reason we were all there was because we had a story of some patient or patients or group of patients that were, injured by our medical system. And at our last meeting in November, they're actually doing what they call white coat boot camp. And what they're doing is they're training people how to record videos, how to do interviews, how to make sure that they have a narrative story, a story of why they're there. So we're actually doing okay with building that little army of people who know how to tell a story. But I think where I'm trying to pull them along is, but we also need to tell them how to paint the narrative that goes along with that story. Because if you just tell the story, a lot of times it can be pivoted back to, well, that's just an economic problem. They don't deserve care. They didn't work hard enough, that kind of. We have to keep that pivot from the narrative of how these people were harmed to why we can do better as a society and why it's important to do better as a society.
Any other questions or comments or chat for Dr. Hughes?
Okay. Well, thanks for being such a good audience. I appreciate it.
Well, thank you so much. This is wonderful. Just a fantastic talk. And anyway, I personally appreciate it very, very much.
Well, thank you. I really appreciate it.
Thanks.
All right, everybody. Have a good night.